Australia, Mexico, Nebraska. It's amazing. If you heard my news, Andrew, retirement. Oh, we've got
1 second.
handing over to young, fresh people, Andrew. Are we on?
Yeah, bear with me 1 second.
I've lost my mouse, Alan.
Right, okay. Okay, everybody, so that's us showing us live on Facebook as well. So welcome everybody to another question and answer session today with Collette, our CEO, and this week's guest medic is Dr. Andrew Yeoman. So I'm sure you'll have a very informative session. Enjoy, and I will catch up later on.
Okay, thanks, Alan.
Right,
Hello,
cheers.
everybody. Good afternoon, good morning, wherever you are, and a big welcome to Andrew from Wales, Andrew Yeoman from Wales, who's one of our popular speakers, very popular speakers. Thank you for joining us. Now, I know we've just been talking about how busy our doctors are here across the world, and it's just lovely that they continue to come in and do this. We've been doing this for over 2 years now, Andrew, with just a break for Christmas. It's been amazing. So thank you. So if you've got questions, Linda's going to be sending them in to me if they're coming in from Facebook. I've got a wee list in front of me, and you can always pop them on the screen, and we'll do our very best to get to as much as we can. And failing which, we'll carry them over to next week, but we'll do our best, and we'll make them dead easy for you, Andrew, okay? First one, can you drink alcohol with PBC?
Oh, that's a so. It very much depends, isn't it? So people will be aware that alcohol is obviously a very common reason for people to get liver disease in the first place. And in terms of what the safe limits of alcohol are, it is different depending on whether you have an existing condition or not. So people will be aware that the CMOs for all of the UK recommend both men and women drinking less than 14 units of alcohol per week on a regular basis. But that's assuming you don't have a liver condition. If you do have a liver condition, it would be advisable to drink considerably less than that again. And if you have cirrhosis from your PBC, then it would be a very good idea to try and avoid alcohol altogether, because even small amounts can be toxic to the liver on an ongoing basis, and your liver won't break it down very, very well. So, occasional alcohol in people with early stages of liver disease from PBC shouldn't be harmful, but certainly be extremely cautious if you've got cirrhosis from it.
Mm-hmm. And I think too, whoever is asking the question, which is a good question that we do get asked a lot, if you're in doubt, you can always drop your liver nurse or your liver doctor, or a wee email as well, because and they'll take into account your own personal circumstances. But yeah, it's a very good question. Thank you. So we're going on. I've recently been diagnosed with PBC and AIH, autoimmune hepatitis. I've been taking Ursula for 6 weeks with no side effects. Fantastic. Started today on immunosuppressants and feel totally washed out and woozy. Is this usual?
No, it's not usual to feel that way. I mean, any medications can make you feel a bit funny, and some people get odd reactions to medications. Immunosuppressants can also make you slightly more prone to getting viruses as well. So, it's another thing that might make you feel washed out and woozy. Certainly these days, if you are able to get a test, I probably would get a COVID test, because the commonest symptoms of COVID now are a bit like the common cold. So most people will get a sore throat, runny nose, feel a bit weird and funny. So always worthwhile, in these current times, getting a COVID test if you are able to. If you've got lateral flow tests, you can do them at home, or rat tests as they call it in other parts of the world. Because I think it's worthwhile excluding other things like infection. But I think if you've got new symptoms since starting a medication, I would liaise with your hospital team, who knows obviously all your current blood tests and what medication they've put you on, because that might need to be reviewed. You might need a blood test to monitor either your liver or your other blood tests. So azathioprine, which is a common drug we use for overlap PBC AIH, can sometimes cause a drop in white cell count, which might need some actions. So I would definitely notify your healthcare team. And if your symptoms are really unpleasant, the safest thing to do in the short term is just to hold off it for a couple of days until you can get medical advice.
Not much is going to change in a couple of days, is it?
No, it's not. So I would certainly say it's not expected for you to feel washed out and woozy. It's not always the drugs, but it could well be. So, think about what it could be. Could it be COVID? So get a test for that if that's possible for you. Certainly speak to your medical team, and then they can review your bloods, and then they can also review whether the medication might be causing an issue for you based on your bloods and your symptoms, and what the best thing to do is with your medication longer term then.
Yeah. Is it possible that this person might be taking maybe 2, 3, 4 other types of medication for completely separate things? And this, I think, one of the most underused disciplines in this country, probably around the world, are pharmacists. So don't discount ever chatting to a pharmacist if you ever have to take anything new or anything either, if you can do that by phone until it's, if you don't think you have COVID anyway. But it's always worth a chat, though, don't you think?
Well, absolutely. So, they might be able to advise if there's any potential interaction. They normally spot those things before they dispense the medications, of course. Yeah. But certainly, I would definitely seek more specific advice from your local team, because it is worth getting that checked over. Many of these things are very short-lived as well to say. So you don't automatically need to be alarmed. Many such things are common viruses that can come along, and they'll often be self-limited. But if you're feeling really, really poorly with it, then the safest thing to do is to hold off the medication until you can get that advice from your local team.
Yeah, absolutely. Okay, thanks for that. It's a good question here as well, and we get asked this a lot. I suffer terribly from joint pain, which I'm really, really sorry to hear from this person. What are the best painkillers to take? Before you answer that, I don't know if this person has another condition like rheumatoid or just arthritic or what have you. So I'm going to offer up, and you can comment about the underuse of physiotherapists as well, because joint pain can be helped enormously by knowing the right thing to do and how often to do it. So that's just one issue, but this is really to do with painkillers. But I'd be interested on your take on it, Andrew.
Yeah, no, I think that's absolutely right. I think the first thing to say is that there's the best painkillers, and then there's the safest painkillers, and they're not always the same thing. And as Collette has said, it doesn't always have to be medication, depending on the type of joint pain. If it's arthritis, then sometimes physiotherapy can be really, really helpful for. If it's an inflammatory arthritis related to rheumatoid arthritis, as Collette has said, or related to things like Sjögren's syndrome, which is commonly associated with PBC and causes a lot of joint discomfort, then there might be different medication that will switch off the inflammation in the joints that will actually be as important for you as just lots of painkillers. So painkillers, remember, are largely, they're just treating the symptom, not the cause. So if you have an inflammatory arthritis, it's important that you get advice from your rheumatologist or your GP about whether the underlying cause for the joint pain needs a different type of treatment. So you're treating the cause as well as the symptom. If we come on to what the safest painkillers are to take, paracetamol remains by far the safest painkiller to take in liver disease of any severity. And it is extraordinarily safe when we give it to people with very advanced liver disease. If you've got cirrhosis, we usually recommend you go no more than 3 grams a day, which is 6 tablets, but most people otherwise can take up to 8 tablets a day, which is 4 grams. Now, at the same time, although it's extremely safe and it can be effective for mild to moderate pain, it's not highly effective for severe joint pains. And so there are a number of other different painkillers that can be used for joint discomfort, depending, as Collette has alluded to, on the underlying cause. So again, inflammatory arthritis and some forms of which is wear and tear arthritis, can respond quite well to anti-inflammatories. So that's ibuprofen, diclofenac, those sorts of drugs. But of course, as you go up the potency ladder, you get more problems with them. And certainly if you have significant liver disease and cirrhosis, then anti-inflammatories are generally not great news, certainly not longer term. And certainly if you have kidney disease or high blood pressure, that can cause problems by being on those things. And long-term use of anti-inflammatories over the age of 55, 60 can lead to problems with stomach ulcers and problems of that nature. So I think, but for some people, they can be very, very effective. If the pain is localized to a single joint, sometimes you can use the topical anti-inflammatories, which are not necessarily ingested. You can buy those over the counter. Again, they can cause side effects, but far less commonly with the tablet ones. So those can be a good option for some people, particularly with intermittent pain. If you don't want to be taking things all the time, and if it's mild to moderate and paracetamol is not quite doing it, then sometimes the topical anti-inflammatory gels can be quite helpful. You're then in the realms, if that's not effective, of going up to what we call opiate style painkillers. So that's codeine and morphine. Now, morphine in itself is, and even codeine is not fantastically good for joint pains by and large, but some people do take codeine for osteoarthritis pain, particularly if there's a lot of bone loss and it's sort of grinding away and causing persistent discomfort. But again, if you have significant liver disease, codeine can make you constipated, and that's something we want to avoid in people with cirrhosis. But also, if you have problems with your bowel function, codeine will make you way more constipated than you are before. So you'll nearly always need to take something to make sure that your bowels are opening satisfactorily, so you're not getting bloating and discomfort and problems like that. Again, codeine can accumulate and cause a bit of sleepiness, or just sort of feeling a little bit ucky and a little bit sort of slow and sluggish. And some people feel a bit spaced out on it because of the morphine-like effect. So the stronger you go, the more potential you have for side effects. But some people do need to take codeine-related painkillers. But what I've described there is that sort of laddered approach in terms of the medical treatment, just for pain. So paracetamol, anti-inflammatories, and the sort of codeine-type ones. But as you said, Collette, always think about things like physiotherapy. For some joint conditions, movement can be as effective, particularly when it's to a structured program or plan, can be very, very effective at minimizing discomfort. And it can also be you need to treat the underlying cause if it's an inflammatory arthritis as well. So there's lots of different strands to it. Single safest painkiller is paracetamol. What's the most effective? It will depend on the type of your joint pain, how long it's been there for, and what other things you've tried before.
If I may add a couple of things, when doctor says, paracetamol 24 hours and 8 a day, that's in 24 hours. That's not a day. That is a whole 24 hours. So please be mindful. The other thing I would say to people with to do with ibuprofen and anti-inflammatories, I do hear a lot on the telephone, and I do report this back to the doctors, of people getting indigestion type of things with anti-inflammatories. So if that's happening to you, report back to your doctor, let him know, and he may want to change it or give you some meprazole or whatever. But don't just suffer it. Go back and talk. And again, another thing about morphine as well, what you were saying, the constipated, I can actually make it quite sick, can't it, Andrew? Morphine, it's there's one thing just on the subject of arthritis. I'm hearing from people being diagnosed with autoimmune arthritis. Is this the same as rheumatoid? I know you're not a rheumatologist.
Yeah.
Is this the same thing?
Yeah, before I answer that, just one final point on the opiate type painkillers. They can make itching worse, okay?
Yes. Thomas Aquinas' Confessions of an Opiate. What was that? Confession of an Opiate? James Newberger got me onto it. You're right. You're absolutely right. Yeah. Always.
So sorry, I digress. Let's go back to the actual question rather than answering the one before. So yes, autoimmune arthritis or arthritis are a collection of conditions that relate to specific autoimmune conditions that can affect the joints as well as other organs as well, of course. Yeah. So rheumatoid arthritis is probably the best known. Sjogren's is an autoimmune phenomenon which can affect the joints, which, as I say, is very, very common in people with PBC. Probably the commonest coexisting autoimmune condition that affects the joints in PBC. Then probably followed by rheumatoid arthritis. Some people have lupus, or SLE as it's otherwise called. And there are some other very, very rare forms of inflammatory arthritis then, but they're all essentially different conditions whereby the immune system has been triggered to react against the body. But instead of being the liver as it is in PBC, it's the joints. So yes, they are kind of interchangeable terms in that regard.
Yeah, okay, thank you for that. Next one, I've been taking Urso for about a month, okay? I take half as my lunch and half as my dinner. You can't take it all together, by the way. I was fine up until a few days ago, and I now seem to feel a bit nauseous after about an hour or two after the lunchtime one. Is this normal or does it settle down? I had a very mild inflammation on biopsy, but no damage. I don't know why you had a biopsy. I hope it wasn't for diagnostic purposes. But you can take this all together. What would you say there, Andrew?
So GI upset, gut upset is the commonest side effect with her. So more often than not, it's related to loose bowel actions. But some people do feel nauseous, and any medication, and it's not necessarily just the urso, but any medication that you take has the active compound that is there to treat the condition. Then it has all these other chemicals in it to try and help your body absorb it, to avoid the effects of gastric acid, etc. Okay, so so those constituents of tablets can also cause nausea. So, I mean, generally speaking, most of side effects that occur within the first month or so will often improve after a period of time. So your body almost gets used to having that that chemical around, and they'll tend to improve. Not in everybody, but a significant proportion of people will have improvements. I think there's a number of different things you can do to, if it is indeed the urso, because it could be something else. If you've been okay for a while, and now it's only started after about a month, there might be something else. And the commonest thing would be is as your bowels got a little bit slow and sluggish on you, because that can make you feel nauseous. But if there's nothing else that could have triggered that, nothing else has changed, and it could well be the medication then that's causing that new symptom, there's a couple of options you have. If you don't have any severe damage on biopsy, then there's always more time. That doesn't mean to say we'd recommend you stopping straight away, and we'd always advise you to speak to your healthcare team. But the sort of options that are available are to either split the dose into 3 doses. So you're getting a smaller peak dose at each time you take it. So some people take also 3 times a day. You can take it once a day, as Collette says. There's no real... the major reason for splitting it is to try and minimize side effects from the medication. So option 1 is try taking the medication across 3 doses in the day rather than 2, because then you'll have a lower peak concentration in your body. And if the side effect is driven by the drug, then there's less of that drug at a lesser concentration. So it's a more smooth delivery throughout the day. The other option is, if that doesn't work, is sometimes your healthcare team will sort of say, well, either stop it, have a period off it and restart, or just drop the dose. So halve the dose a little bit and then build it back up again. Because in many people, if you do reduce the dose, and I do this a lot with urso, the number of people who are actually truly intolerant to urso is actually quite small. Probably 5 to 10%. If you just take a single symptom and say, right, that's it, you're not having urso anymore, then you're probably about 20-odd%. But actually, if you're changing the dosing in terms of the number of doses you take in a day, that can help, or reduce it down and then build it back up again. The other option as well is if that doesn't work, then you can change the preparation. There's more than one different preparation of urso. And so, as I say, it's not always the active drug that causes side effects from the medication. It can be the other constituents. And in the different preparations, they're all slightly different.
Like the capsule, the gel and the capsule, sometimes a pharmacist is going to that. Some people find that a bit of an irritant. You're absolutely right.
Yeah, absolutely right. So those are the sort of options available to you. So yes, it may well be related to the drug, but I think certainly there's a couple of simple things that can be done to try and minimize that for you.
And if it's any help to this person, I do hear on the phone people tell me that they've suffered a bit of nausea, but they take it all at night before they go to bed. So that's it. So there's that option as well. But keep in touch. But it should settle down. It's a great treatment for PBC. It really is.
Yeah, we'd certainly encourage you to carry on taking it to try and prevent the progression, because it's such an important medication.
Yeah. I've been on it 100 years now. How is ammonia? Do you know, when I was first diagnosed, there was no urso. And so it came 2 years later, and very happy. Right. How is ammonia related to hepatic encephalopathy? And does high ammonia cause hepatic encephalopathy? It's a difficult word, that. You doctors have got some tough ones to pronounce.
Is that from George Mells, that question?
Oh, probably.
It's a really good question. It's a really in-depth question.
I'll sort him out later.
Do you know, it's a really fascinating question, because there's potentially a lot to talk about in terms of ammonia and hepatic encephalopathy. So I'll break it down because obviously the person who's asked the question clearly understands hepatic encephalopathy, but other people on the call here today might not. So hepatic encephalopathy is a specific complication that people with PBC will only encounter, not exclusively, but if you have cirrhosis. Okay, so if you have cirrhosis from PBC, then at some point, maybe about 40-50% of people in your lifetime will suffer from an episode of encephalopathy, which is where the scarred liver isn't able to break down ammonia adequately enough, and then that has negative effects on your brain function, and it can cause a brain fog. Separate to the brain fog you can get from PBC, or additional to that, it can affect your balance and your motor function, and it can certainly make you feel just slow and sluggish in everything you do, and can cause bouts of confusion and even sleepiness. So ammonia is very much at the heart of why people get hepatic encephalopathy. So it occurs when your liver can't break down ammonia, but there are other organs that can break ammonia down as well. Your muscles and your kidneys are important sources in the body, or places in the body where ammonia can be broken down. So it's another reason why it's important to keep your muscle strength up in any liver condition. So it'll help your muscles break down some of the waste products that a liver can't always do when you have a liver condition. But in terms of how it relates to encephalopathy, what will happen is that if you're one of those people for whom your liver's not breaking down the ammonia very well, the levels in the blood will increase, and affect in the end that will affect your brain function, because it will cross over into the brain. So the slightly complicated thing is that actually the absolute level of the ammonia in your blood doesn't correlate very, very well with the degree of the encephalopathy as you experience it. So some people, it can be extraordinarily subtle, such that you can't really spot it without doing specific tests. But in other people, then it can just cause slight word finding difficulties, or very subtle things with their perception and their coordination. And in extreme ends, obviously, people get very, very drowsy and confused with it. But even in those people who can be confused with it, the ammonia levels can only be very slightly elevated. So even though ammonia is at the heart of why people get encephalopathy, a blood test to measure ammonia doesn't always tell you how badly you might be affected. And certainly I've looked after people who have had really high ammonia levels and have very little in the way of effects, because their bodies kind of got used to that. Whereas if you don't normally have a very high ammonia level, and then it suddenly goes up even a little bit, then that can affect you quite significantly. So ammonia is very much the underlying sort of trigger, if you like, for causing all the brain dysfunction that represents what hepatic encephalopathy is. But actually, the ammonia level doesn't always have to be very, very high for you to actually be affected by it. So it's a fascinating thing, and it's the other thing that seems to modulate or alter how ammonia affects our brains is whether you've got inflammation in your body system at that time. So if people have infections that have driven this deterioration in the liver function, causing ammonia to go up, then a lower ammonia level will cause more profound effects than if you haven't got that inflammation on board. So there's something about the inflammation that affects the way our brains respond to a slightly higher ammonia level. So it's a very fascinating story. Biologically, it's very interesting.
Don't they treat it with laxatives?
Yes, we do. So we use the initial treatment for ammonia. Well, first thing, we look for precipitants. So if there's infections, sometimes just treating that will sort it out. Sometimes it can be triggered or brought on by dehydration, either from a bout of gastroenteritis, or if we're using water tablets to clear fluid from complications of liver disease. So treating those things can often make it better. But yes, the first line specific treatment for hepatic encephalopathy is lactulose, which is an old-fashioned laxative. And what lactulose does is it increases the throughput through the gut. So it's a laxative. It makes you go to the toilet more often. And the reason why we produce ammonia is the bacteria in our gut convert protein into ammonia. And so what the lactulose partly does is it partly clears the bacteria through the gut, so they have less time to produce the ammonia in the first place. And it also sort of actually directly blocks the bacteria's ability to produce the ammonia as well. So overall, it will tend to reduce your ammonia levels and reduce the severity of your encephalopathy. And if that doesn't work, there's an antibiotic called rifaximin that can be used, which again just knocks out bacteria in the gut to try and reduce some of the production of ammonia to minimize the effects of encephalopathy. But it's a brilliant question.
It's a very, very good question. And can I also point out, just so as not to worry people, that this is not common. This is quite rare symptom of late stage PBC. So I don't want people worrying and thinking it's going to happen to you.
Absolutely right.
it's rare. Okay, we crack on. The questions are firing in on my other tablet here. I previously had an AMA test which was negative. I've been having some abnormal blood tests, liver, thyroid, and bone, and I have MS. My GP is not interested in my concerns that I may have PBC. Does a negative AMA result ever change? Can you please give me some advice on how to handle a GP that is not interested?
Yeah. Okay.
Change your GP.
First thing to say is a negative AMA can change. Okay, so I think we know, flipping back the other way to begin with, if you have a positive AMA, that doesn't automatically mean to say you have PBC now, but we know from the original work from Newcastle that Oliver James did back in the day that showing my age now.
Showing mine.
That if you have a positive AMA, then at some point in your life you'll almost certainly develop PBC, but obviously it could take several decades.
Yeah.
However, not everybody who will develop PBC will have an AMA positive from birth. So it's something that gets switched on, if you like, at some point in your life. So autoimmune conditions can be regarded as a genetic predisposition to your immune system attacking yourself, but something triggers it. It can be a medication, it can be a virus, it can be other things. Like, there's been a lot of interest in things like hair dyes over the years and different things. So something in your environment triggers your immune system.
Women dyes here. That is just not true.
I know, but there's been all sorts of, people have always looked for triggers, haven't they?
Yeah.
But certainly, in general terms, autoimmune conditions are, you have a genetic predisposition, so you're born with that, you can't alter that. Then something in your environment will trigger your immune system that may make it react against you. Not for everybody with a predisposition, but for some people. Mm-hmm. And so, in that sense, if you haven't had that triggering event, your AMA will be negative. Okay, and so that can change over time. So having a negative AMA a year or so ago doesn't mean to say that can't change in subsequent years. So it then comes down to what is the symptomatology and the other drivers to consider a diagnosis of PBC for yourself. So do you have a raised alkaline phosphatase, for example? Because if you do, then certainly you need to start looking in more detail about whether you could have PBC. You have one autoimmune condition, namely MS already, and so you can have more than one autoimmune condition. So if you have a raised alkaline phosphatase, then certainly additional testing might need to be considered to try and make a diagnosis of PBC. If you don't and you're AMA negative, you probably don't have PBC, in all honesty.
Yes, alkaline phosphatase really, or the ALP is the key here.
Yeah, absolutely. Because unfortunately, some of the other symptoms that you will see associated with PBC can occur in other conditions as well. Mm-hmm. So people can get pruritus for conditions other than PBC. People can get fatigue for conditions other than PBC. So given that, generally speaking, if you haven't got a raised alkaline phosphatase, we wouldn't regard you as having active PBC in the vast majority of cases. So I think if your ALP is elevated, then normally the simplest thing to do would be to check your immunoglobulins, which are little proteins which produce antibodies in your blood, or which are antibodies in your blood. And the IgM one sometimes goes up if you have PBC, but that's something that your doctor can consider. Yeah. So I think it really hangs this question on whether your alkaline phosphatase, your ALP level, is elevated, not about how much you need to push for additional testing.
Yeah, I would also say to this person, can you give me some advice how to handle a GP that's not interested? I'm not a doctor basher. It's just not what I do. I try to get the best out of people. And I would say in any doctor's defence, in any accountant, professional, anybody, sometimes people can appear not interested, but they just don't know what to do or how to take things forward. If you really felt this doctor wasn't interested, I would think about changing your GP. But equally, you've now got a bit of knowledge. You can go back and ask your GP about your ALP, alkaline phosphatase, etc., and see how they respond to that. And, have an honest chat with the doctor. If it's not his thing, he doesn't know much about it, he's maybe very uncomfortable, then he might want to pass you to someone else in the practice, or maybe it is best that you move on to another doctor. But I'm just a bit, I don't like doctor bashing, but have the chat with them and tell them how you feel. That don't see she. Is that reasonable, Andrew?
Yeah, I completely agree. I mean, I hadn't addressed the second part of the question, and I think, but you've done that for me. I think that's right. I think everybody has the right to a second opinion. I think the first thing is what is there that suggests that we need to really consider a diagnosis of PBC? Because it might just be that actually if your ALP is elevated and you go back to them, they might just go, okay, then, well, yes, that's fine. Then we'll need, they'll either make a referral on to the local hospital team for an opinion, or they might do some additional tests themselves. But ultimately, you are always entitled to ask for a second opinion if you're not happy with the information that you've got. But as I said, we're here to try and help you as best we can with that. But I think for me, whether you need further testing really hinges on whether you have a raised alkaline phosphatase or not. And if you have and you have one other autoimmune condition, for me, that means I always have to exclude PBC.
Okay, thank you. Okay, I started our show in February, 7th February, just this year. ALP was 1374, ALT 387. And on the 28th, the bloods was ALP 855, fantastic. 307 is down, and then down to 800 and 216. Is this how levels are meant to go, or do I need to be put on another medication? This looks like great news, doesn't it?
It looks like very good news. Yeah, absolutely. I mean, I think first of all, your ALP is pretty high to begin with, and you've got a pretty high ALT as well. So you have what us liver doctors call very inflammatory PBC. So so some people's ALPs and ALTs do seem to be much higher than other people's. And I think it is very important that we try and bring those levels as close to normal as we can. Now, obviously, what I would say is, ERSO takes a good while to work. So actually, the fact that you've had such a prompt fall within really a month is very encouraging.
The manufacturers tell me, Andrew, that it takes 16 full weeks to get into the system. That's what I've been told historically.
Yeah, look, we don't, when we talk about second line treatments in PBC, at the moment you have to be on ERSO for 12 months, which gives you an idea of how long it takes to have an effect.
So you're looking at trends then.
Yeah, but in reality, the bulk of the improvement you will see on ERSO will have happened by 6 months. Okay, so certainly what I would say is that your response so far has been very encouraging. It is actually quite brisk, which is good, and both your ALP and your ALT are improving, which suggests this is primarily PBC rather than an overlap syndrome. What I would say is that people who have very high ALPs and ALTs may be in a group of patients who may be more likely to progress in terms of damage. I'm not saying you will, but on average, if people are going to progress in terms of scar tissue, it's younger patients, and patients with very high levels like that are slightly more likely. So what's really important is that we get your tests as close to normal as you can. So we're always aiming for an ALP of less than about 200. Okay. Now, at this point in time, it's far too early to say whether your ALP will drop below 200. But certainly it will be important that you're having another review with your bloods around that 6-month mark to see how close you are to 200. And sometimes you find with ERSO is that you get a really, really rapid fall, and then it'll just, it will then just stay at the same level. So it will have worked to some extent. You'll be what you call a partial responder. And so it'll come down from 1300 to maybe 500. But if it gets stuck at 500, then it hasn't budged below that at 6, 7, 8 months, then at 12 months, it's not likely to go below 200. So the time to start to consider whether you might need a second line treatment is, you wouldn't start it at 6 months, but you're starting to think around that 6 to 9 month mark about whether you're going to get close to 200, and therefore whether you might need additional medication. Fingers crossed, it might continue to come down and you don't.
Absolutely. Could this person, is it safe to take the contraceptive pill?
Yes, I mean, I think generally speaking it is, yes. I mean, I think with any new medication, you want to try and get a sort of reasonably steady state with the previous medications you're taking for a new condition. Generally speaking, when it comes to liver conditions and contraception, we usually recommend either the progesterone only pill or a low estrogen dose. Okay, so that's a mini pill for is low estrogen, or there's a POP, which is a progesterone only pill. The reason for that is that high doses of estrogen can cause a little bit of liver inflammation can cause a little bit of fatty liver as well. So so generally by using lower doses of estrogen, it's less troublesome in terms of flicking the liver test back up again and then creating a challenge. Is it PBC? You're not responding to the drug, or is it the contraceptive pill? So, but no, contraceptive pill is generally very safe, but low estrogen dose or progesterone only is better.
Okay, right. I'm on to the tablet now, and I see you've got a question here, Caroline. I'll come to you. Let me get these ones in first, okay? So I've had 2 shots and 1 COVID booster. The last vaccination was nearly 2 months ago, and the spot the needles was inserted still stings when I'm under the shower. The needle didn't sting. However, when the fluid went in, it hurt. And when it hurt when the nurse stopped and then continued. Should I have another booster?
Yes, you should. I don't think that's a vaccine-specific effect. That's called having a needle stuck in your arm effect.
Right. And this could all settle down, couldn't it?
Yeah. So that it's probably a very, very low-grade nerve injury. So when you think about it, when you're sticking a needle into the skin, there are nerve endings there. There's no huge nerves in the skin where they tend to stick it in what we call the deltoid muscle in the upper arm. But there are tiny little nerves which obviously you can't see. And we've all had vaccinations, I think, where one of them's hurt more than others. Yeah. And that's usually where you've just literally pranged a nerve. And then when you're injecting around that, then just the volume you put into the muscle can actually just injure the nerve a little bit. And it's probably why when it's you've sensitized it then, and that's probably why it's uncomfortable when you're in the shower. Yeah. So either the pressure from the shower or the change in temperature is just sort of alerting that nerve and irritating it again. So these things will tend to improve. There's nothing to suggest that should happen again if you have another jab, but probably just change arms.
Yes, indeed. I'm not sure that we can answer this question actually in full anyway. I'm not sure it's clear. Could you please tell me PBC could cause a mass on your bile ducts? Is this a possible side effect?
So PBC shouldn't cause a mass on your bile ducts, not directly as a consequence of PBC. So people with PSC or primary sclerosing cholangitis are prone to developing lumps and polyps in their gallbladders. That's not something we associate with PBC itself. One thing we do see in some people with PBC that can be spotted on scans is it's not uncommon to get small little lymph nodes that are slightly enlarged around the liver and around the gallbladder area. And as long as they're not particularly big, then they can be just considered related to having an autoimmune condition of your liver. So we do see that from time to time, but a lump within or mass within the gallbladder shouldn't be directly related to PBC, and it does need consideration. The commonest thing that would cause a lump in your gallbladder would be a polyp. As I say, it's like a little wart, I suppose, in your gallbladder, and many of them won't cause any problems. But if they're reasonably large, then sometimes the gallbladder needs to be removed to be dealt with, or if it looks a bit more worrying in terms of size, then you might need additional scans and then having it removed. But it shouldn't be related directly to your PBC.
Okay. Now, there's a good question. Is it true that the younger you are when diagnosed, the more aggressive form of PBC you have or can have? Now, before I let you answer that, I want whoever asked this question to be aware that, that these things happen, but they also don't happen too. Now, I'm going to tell you just briefly, I was diagnosed when I was 37. I had the symptoms since I was 17, but I wasn't believed or understood. Now, when I first presented this to James Newberger when I was 37 and a half, when we got talking about these things, he said, "You're not unusual. That is not unusual to hear that people have had symptoms for many, many years. And these days, people know a bit more about PBC. So I think bear that in mind when Andrew answers this question. I don't want you, if you are a young person, to feel, oh my God, I don't want you to be overwhelmed with worry and concern. But I know what you're going to say, but go for it, Andrew.
No. It's a really important question. And I think I've already alluded to it earlier when I was talking about the high ALP, is that younger patients and those with the high ALP are ones that we really want to get the ALP as close to normal as we can, because on average, and that's the key phrase, on average, you're a bit more likely to develop progressive scarring of your liver. However, and this is another key point, not everybody with PBC will develop scarring of your liver. Okay, we know that probably across your whole lifetime, about 40 to 50% of people with PBC will develop significant scarring to the point of what we call cirrhosis, but that means most people don't. And so that is actually determined by something that we can't tell at this point in time. It's related to your genetics and how your body reacts to having PBC. And in some people, even though your bile isn't flowing properly, it doesn't lead to damage. In other people, it will. The only way of assessing that is to monitor you over a long period of time. But in the meantime, before we're waiting to monitor you, the most important thing then is that we're getting you on effective therapies to bring your ALP down, because we know that that does impact what we call the natural history of the condition. So we can't change your genetics. We don't know whether you'll develop scar tissue just yet, but we do know that if you're taking URSO and you are an URSO responder, or if you don't respond to URSO, having a second-line therapy like OCA is really important for you. And then the third bit that's really important is that we continue to monitor you to see if you are developing progressive scar tissue in your liver. And the thing that we don't do as well as we could as a community right now, but I think hopefully will change in the future, is we'll start to be better at monitoring with tools like FibroScan to see if you're developing or ELF test, whatever you've got available locally, to monitor how much scar tissue you've got in your liver. Because we've started doing that locally now, and actually I find it very helpful, because some people are really anxious because they were diagnosed in the PBC era where it stood for primary biliary cirrhosis, and always assumed they had cirrhosis. And we did a number of FibroScans on people, and they were completely normal, and they'd had the condition for 25 years. And we were able to say to them, do you know what? You don't have cirrhosis. What you do have, you have a condition, and it does cause itch and it does cause problems for you. But actually, if you've had it for 20 odd years and you haven't got any scar tissue, you're never going to get cirrhosis at that point, you know. So I think the monitoring of this and looking for the amount of scar tissue in the liver and monitoring that is a really important thing. So, as I say, we've got 2 good treatments now for PBC, whereas when Collette was diagnosed, there were no treatments for PBC. There are other trials out there, and obviously fibrates that we can use as well, which are not licensed but are effective and safe for the vast majority of people. And I think we are looking increasingly at different combinations, and I think we will see in the future people will probably be on, or non-responders will be on, a minimum of 3 medications and possibly 4 or more, because anything we can do to reduce the ALP levels will further reduce your risk, because it's not inevitable you will develop scar tissue. But if we treat you and we get your ALP down, then the risk of that happening for you is going to be much, much smaller than if we don't.
And don't forget, there's been a UK PBC audit. Andrew's been part of this, and this has been fantastic. A lot of information has come out, and a lot of avenues identified where we could all do a bit better, us as patients and doctors, and this is great stuff. Right, I'm going to hammer on because we've got loads of questions. I'm at stage 1, new diagnosis of a serious dry mouth. Any help with suggestions? Which is 1, and my ANA is now high 2. Is this normal? I'm just going to go to the dry mouth, and I'm going to say to this person, it's not unusual. This Sjogren syndrome, Sika syndrome, with PBC. What is really important is mouth hygiene. And if it hits your eyes, you know, eye drops, oily ones, they last longer, and you can wear your mascara, not yourself, of course, Andrew. But mouth hygiene is really important. And please, and our dentist has told me this, and James checked it out, do not use chemical-based solutions bought in chemists, things like Corsidol and all the rest of it. Do not use them as mouth washes, because they will dry out your mouth further. They change your taste, they discolor your teeth, change the taste of your food. Warm salt water. You brush your teeth, warm salt water. But do talk to your dentist about getting things to help keep your mouth as moist as possible. Would you add to that if you get into it?
I think that's absolutely nailed it. I think it's if you have the dry mouth, the Sika syndrome that's associated with PBC, there isn't a cure for that, unfortunately. So it is managing it, and as Collette said, it's use the least chemical solution possible. Certainly for eyes, you're absolutely right. Oil-based, drops are far better in terms of duration of effect. The other thing that can sometimes help with the dry mouth stuff is actually having things that have citric acid in them. So that's citrus fruits, because they stimulate a bit of saliva production.
Of course, yes, of course.
So I'm not saying you have to be drinking gallons and gallons of orange juice, but certainly things that do contain some citric acid, they do help stimulate a bit of saliva production. And you can get sprays as well that can be helpful if you're having extremely dry mouth. And if it is extremely dry, then as you say, having some input from either a maxillofacial surgeon or a dentist is important, because actually you do require saliva for good oral hygiene as well. So it's really important that that's addressed for you. But it can be a really troublesome problem.
And it can come and go as well. Don't think you're going to be landed with it necessarily all the time. It's flexible, like most symptoms of PBC. Very, very quickly, my ANA is now high. Too. Is this normal? Very quickly.
It's not uncommon, basically. So again, ANA is another antibody, or we call an autoantibody. So it's something that we can measure in the blood. Is quite commonly seen in people with both PBC and autoimmune hepatitis, but it doesn't denote that you're more likely to have more severe PBC or is more likely to progress. If you measure enough people's ANA levels, certainly as you get my age, late 40s, 50 and above, you'll find a lot of ANAs positive in people, and it doesn't mean that you're going to develop a specific problem. It's all in the context of appropriate symptoms. So if you've got PBC and an elevated ANA, it's kind of like, it's not a surprise, and it's not a worry for me.
Okay. And Mona's just said, I use coconut oil as well for mouthwash. Mona, thank you.
Yep.
I have autoimmune hepatitis. Will it make my PBC worse?
It will make your PBC worse. I think what you always have to think, if you are one of those genetically predisposed people to developing scar tissue, then having two conditions that could be inflaming the liver in different ways could potentially make that worse. That isn't necessarily a bad thing for you as long as you're having both conditions treated. So as long as you're having your liver tests monitored and your treatment modified to make sure that you're, with autoimmune hepatitis, we try to get your ALT enzyme level normal. And obviously with PBC, we try to get the ALP as close to normal. So it would be perhaps a really strong focus on both of those things to get them as close to normal as we can. And also, if you have two things that could be damaging your liver, make sure there's not a third. So be cautious with your alcohol intake. Make sure you've got a healthy weight so that you're not developing any fatty liver. That could be a third reason that could causing some liver inflammation and additional damage. So in and of itself, no, as long as you're under treatment and as long as that treatment's working.
Brilliant. So next, we're going to get through quickly. I've had diarrhea on and off the last 2 weeks. I've had PBC for 4 years, 42-year-old female. I'm wondering, is this my condition deteriorating? How can I control the diarrhea? You must report this to your doctor. I would say this to anybody with any condition, any change. A change that's not just for a day or two, any longer than that, like you're saying 2 weeks, you really need to report that to your medical team. But go on, I'll let you answer that.
Yeah, absolutely. Your medical certificate's in the post, Collette. I think I completely agree. In all seriousness, no, new symptoms, we shouldn't always blame every symptom on our PBC. We should explore to see if it is or not. This is, change in bowel habit should not be related to your PBC. If it's a new onset thing, it needs reporting and it needs actioning as per anybody else. And it shouldn't really matter that you got PBC. This is new change in bowel habit. Most of the time, that still that transpires to be nothing, but it's always important to get it checked out.
Yeah, and the next one is even more of a concern. I'm worried my condition is getting worse as having increased fatigue and itch. Before I go any further, just so everybody knows, your level of symptoms does not correlate with where you are in the disease. If it's progressing, your symptoms sometimes don't change or get better. So that's quite not the case. This does concern me. I have a 15-month-old child and still feel super wiped out. Some days the brain fog and headaches are tremendous. Can you help? Again, this lady needs to see her doctor, doesn't she?
Yeah, absolutely. I mean, I think you've got two very plausible reasons for why you'll feel fatigued without having a progressive liver disease. PBC itself, as Collette has said, isn't always, the severity of your fatigue doesn't correlate that well with your liver disease, although it can do in some people. In most people, there's no strong correlation between severity of fatigue and progression of liver disease. Having a young child is exhausting. But at the same time, we're not saying we should blame it all on that, but it could be a combination of those two things. But if you've got worries that this is worsening, then the important thing to do is to get it checked over, get your liver bloods done to see what your PBC status is at. You can find out about how much scar tissue or not is in your liver. More often than not, if you're young enough to have a young child, it's unusual to have advanced scarring from PBC, but it's not impossible. So it's important that you get this just checked over. Other things to remember as well is that people with one autoimmune disease can have others, and it's quite common to get thyroid disorders. So get your thyroid checked over, for example. There might be some other very easily treatable things that might be driving some of this. It's not always due, as Collette says, to anything dramatically worsening with your liver function. In fact, more often than not, it's not related to that. It could be related to an associated condition, but get it checked out, get your bloods done, get your thyroid checked over, and then you'll know and have that peace of mind.
And I would say to this person as well, if you contact the office, they'll give you my number, and we can have a wee chat on the phone how we can progress this. And it must be very, very difficult for you with a wee baby. So please do contact me, and let us support you as best we can.
Yeah.
So am I right in saying you still have PBC after a liver transplant?
Yeah, no, that's a good one, isn't it?
Well, of course, this came up, I think it was yesterday or last week. I mean, we do know people who will get it again, and James Newberger always used to say, well, sometimes it's just academic because its lifespan is 30, 40 years. You might not get a transplant till you're in your 50s, you're now in your 90s if it appears again. But I know the liver units, the transplant units are starting to give transplantees or so anyway.
Yeah, again, there's no good evidence for that, but I can understand the rationale because it's safe. People are usually taking it before. So we generally say about 20% of people who've had a transplant for PBC will develop recurrent PBC within that transplanted liver at some point in the rest of their life. But as we know, is that if you get to transplant with PBC, the vast majority of people will be over the age of 50, 55. And so it's taken a long time for the liver to get that damage. And as James Newberger rightly says, I mean, you wouldn't argue with James on this, would you? Because who knows more about it than him? But he's absolutely, but actually all the evidence shows that actually, even if you do get recurrent PBC, it's pretty rare that it leads to the need for a retransplant. However, it doesn't mean to say that you might not get symptoms of your PBC recurring. And I still don't think we know enough to sort of say how it moderates the symptoms. But by and large, in most people, it seems to be based on biochemistry, where the blood tests go up a little bit again and will often respond to urso. So for the vast majority, it's mild. The broader thing is we still really shouldn't be talking about liver transplantation as a cure for any liver condition. We should regard it as a very good and a very effective treatment. But ultimately, transplantation brings its own risks for whatever reason you've had the transplant for. And you need lifelong monitoring, and you have your kidneys checked over, and you have to make sure you're fastidious with your skin health to reduce the risk of skin tumors and whatnot. So transplantation should be regarded as a treatment, not a cure of any particular liver condition. But as I say, very rare that PBC causes recurrent disease that's bad enough to need to retransplantation.
Absolutely. And it's good to know that we transplant less for PBC than we did years ago, which is
a lot less.
A win-win. Another one, I do feel it for people. I've been told to stop breastfeeding as I'm going on to bezafibrate. Does this help with the tiredness? Is there anything else otherwise that can alleviate fatigue? I'm going to say I'm a big fan of movement as medicine, but when you've got a young baby and you're breastfeeding, you're going to be exhausted anyway. I would recommend this lady just gets her blood checked as well, and just see there's nothing thyroid or anything else going on, but you'll know about the bezafibrates and breastfeeding.
Yeah, I mean, I think it's a challenging one. I think first of all, bezafibrate won't improve your fatigue at all. If there is any benefit from fatigue from therapy like bezafibrate, is that if you're tired because you're not sleeping because of itch, and you can improve the itch, which we know bezafibrate will do in about 40% of people, then that will make you feel less tired because you're getting more sleep. But specifically for fatigue, bezafibrate doesn't have any impact at all. And so if you've been advised to stop breastfeeding for that reason, then that's sound, because you need the bezafibrate for your liver disease. The challenge of fatigue remains. The itch is still a very significant challenge, and fatigue is just the next level above in terms of a challenge to manage, because we've never had an effective therapy. Whereas we know that some people still struggle with itch despite several therapies, but there are at least several therapies that we can use for itch. At the moment, we have graded exercise programs, the movement and medicine type approach. There's been a few trials in the past looking at drugs like rituximab to see if that improves fatigue, and those have all been inconclusive, or in other words, not been shown to be helpful. There are some additional trials on the way. And so that's the option, is to discuss with your doctor if you can be plugged into one of the large centres like Birmingham or Newcastle, who will be recruiting people for those trials. That's another option. But again, coming back to Colette's point, make certain there isn't an associated cause like a low thyroid function that could be driving some of that. So yeah, it remains a huge problem, unfortunately, fatigue. And your bezafibrate wouldn't really help that anyway. But it sounds like you probably need that for your PBC and your ALP levels, most likely.
I would encourage people as well, you know, it's very, particularly when you've got a young baby, God, it just brings back memories, you know, to want to go back to bed for an hour and what have you, and that might be fine, but also get the baby out in the pram and have a wee walk around the block and, you know, give yourself a bit of fresh air and just a little bit of that. Don't feel that having a rest and lying down is going to resolve a lot of fatigue, because it doesn't. It can often just, you know, exacerbate it. So you want to find a balance. But, you know, who am I to tell a young mum? I went through it with 2 young children, and I do understand. But, you know, I'm on the phone. If you want to give me a wee ring and you want to give me a bit of information, we can chat some more. We've got a belter of a question here, an absolute belter. I've got fatty liver. Is this common with PBC? No, it's common with COVID. All yours, Doc.
So is fatty liver common in PBC? Fatty liver is common in the general population. So
absolutely. And it's a big problem. We mustn't shy away from this.
No, not at all. It is an important issue, and I think it'll become increasingly important in the years to come as a potential cofactor that will drive liver disease progression in some people, not in everybody, but in some people. So if you take the general population, 30% of people will have a fatty liver. As the population gets heavier, which it has done over the last 20, 30 years, that will increase to probably 35%, and probably in a decade or more, it'll be more than 40%. So the likelihood of having a fatty liver is almost directly proportional to your weight gain and to your body mass index. So if your BMI is above 30, about 50-60% of people will have a fatty liver. If it's above 40, then about 90% of people will have a fatty liver. So fatty liver will be very, very common, but it's not because you've got PBC. It's just a secondary thing that you've got because largely because of whatever your body weight is. It does become important, as I say, because it might facilitate progression of your liver disease, and it can also be associated with other health conditions such as type 2 diabetes, cardiovascular problems like angina, and other heart issues. So, you know, modest weight reductions can help, and the advice is that between 7 and 10% of your current body weight will resolve, not all, but a significant amount of your fatty liver, and it will also reduce the risk of other health conditions. And if you do have fatigue, it might help with that in terms of movement. It might actually support an exercise program, or an exercise program is a good way of bringing about small amounts of weight reduction. And we know that in some limited studies that it reduces the amount of fat, inflammation, and possibly scar tissue in your liver as well. So as well as the broader health benefits around reducing your risk of diabetes and heart disease. So if you have a fatty liver and PBC, really important to think about that and what that might mean for both your liver and your general health as you grow into hopefully old age.
Absolutely. And you know, we can give you more advice and more help on that. Absolutely. But it can be done. Please don't think because you've got PBC you can't lose weight, because I've just lost 3 stone 9 pounds and I didn't think I could do it. Is there a medication that helps inflammation through your entire body and cranial pressure? I don't know what cranial pressure.
Cranial pressure, I mean, refers to the pressure of the spinal fluid in your head. That's what it means in a medical sense. But some people use the term to mean they get lots of headaches. So you can get headaches if your cranial pressure goes up, but actually people feel like they've got a pressure headache even though the cranial pressure can be normal. Is there medication to reduce was it medication or diet?
Medication.
Yeah. So In the context of PBC, we use urso to improve bile flow, and that can improve inflammation within your liver. But it shouldn't have any impacts on inflammation if there is inflammation in other parts of your body. So the medication we use for your PBC is targeted to your liver only. I only mentioned about diet, I think, because I think Colette's put a question on the chat about how to keep inflammation down, the role of good gut health, and that sort of speaks to diet. So I think, no, there isn't a specific medication that can do that. It is, from a PBC perspective, managing your ALP, managing any pruritus you've got, managing your fatigue as best we can within the limitations of those things, looking at movement as medicine, looking at good levels of physical activity, eating well, trying to minimize fatty liver. Those things can have some benefits, but of course some people will still get additional symptoms such as recurrent headaches, but those are probably not directly related to your PBC, although they might be exacerbated by a loss of sleep from itching, etc., etc. But they will be only secondarily related to you having PBC rather than driven by it.
Well, just as you mentioned, Carolyn, there, she talks about good gut health, and generally we are running out of time. How are you for time, Andrew?
I'm okay. Yeah, I'm okay.
She mentions the role of good gut health. My findings, if you like, I know lots and lots of people whose gut health improved enormously by ridding their diets of sugar and processed foods. If you read people like Mike Mosley, I actually met him in Edinburgh, and you listen to him about live yogurts and various things. It's something I think we should all try ourselves, what's good and bad and what helps us and what doesn't help us. But I don't know that we actually can advise people on good gut health for PBC, can we? What do we know?
No, I don't think we can advise on good gut health generally, because we know that having poor gut health is associated with lots of health problems, and not always physical health, but actually there's a really interesting study from the US where they did fecal transplantation via capsules containing bacteria in people who are addicted to alcohol, and that reduced people's cravings for alcohol, would you believe, right? So the signaling that happens in the gut and the interaction between the bacteria in our gut and our bodies and all our biochemical processes is much more profound than we truly understand. We do know when that becomes what we call dysregulated or abnormal in its balance, that leads to increased risk of gut problems, liver problems. It can even drive some types of cancer. I'm not talking in relation to PBC now, I'm talking more generally. The problem is we don't yet know how to manipulate it and to bring that balance back into some degree of order. So I know that poor gut health is associated with other health problems, but we don't yet know the optimal way, individual to individual, to manipulate that. And it is important because everybody's gut, what we call microbiome, that's the different types of bacteria, the balance of them you've got in your gut, is different in everybody. Everybody has a slightly different balance. And so for that reason, we don't yet understand how that can be manipulated. So some people do find that live cultured yogurts can improve their bowel symptoms, for example. Other people find that it doesn't. And it might be that it's either the wrong treatment or the wrong bacteria we're giving. So it's still a very grey area in terms of what the effective treatment is.
It is.
And I think it works for you. Good luck to you.
Well, absolutely. And if anybody wants to know the two things that helped me was live yogurt. I have 100 grams every morning. I'm not a big dairy fan. But also, I cut down my fat to olive oil only. I gave up butter and everything else, and I no longer have IBS symptoms. Now, that was me. Go and have an experiment yourself. Don't be frightened to do it. Have a bash. Have a bash. Keep off the sugar. You get that one Easter egg.
I think Mona's come in and said, can digestive enzymes, probiotics help with gut health? Yes, they can. I mean, I think that they've been found helpful in people who've had gastroenteritis in terms of recovering your symptoms from that. So it can help restore gut balance when it's been unbalanced by acute infections. They're generally quite safe, but again, if you've had very advanced liver disease, so if you've got complications of cirrhosis, probably best avoided because sometimes that can cause infections. But in most people who haven't got advanced liver disease, they're perfectly safe, although they may not benefit everybody. Diet is really important. Carbohydrates, yes. Actually, what's interesting is that when we look at all the trials where they do fecal transplantation as a treatment for lots of conditions, lots of inflammatory conditions, when they're looking for donors to produce the feces, Vegans are the super donors.
Really?
Yes.
Interesting.
So actually,
something to think about when I speak to you.
It's terrible news for a carnivore like me, but actually, a high meat diet is probably not great for good gut health. So, a plant-based diet is probably better for your gut health.
Interesting. My liver functions were all normal. My AMA and ANA were high. So a biopsy was done to confirm PBC. God, I wish I'd stop doing this. Which showed signs. It's normal to have PBC and normal. Is it normal to have PBC and normal liver levels? Well, it was quite complicated because my AMA and ANA were high. So they did a biopsy, which they shouldn't have had to do, which showed signs that normal to have PBC and normal liver. Is it normal to have PBC and normal liver levels? You can do, can't you? I mean, people do have PBC.
Yeah, you can do. I mean, I think, as I said, when we talk about people having a normal ALP enzyme level as not having PBC, there will be some people who will have some very early PBC with a normal ALP level, but it's probably not going to be clinically significant at that stage. So it's, we don't do very many biopsies for PBC any longer, and because whether you'll be significantly affected by it, at least in terms of your liver health, is dominated by what happens to your ALP. If your ALP is normal or near normal, then it's probably not going to be very, very significantly active. It's going to be early stage PBC at best, or at worst rather. So we don't do very many biopsies. So it's probably not that common that people have completely normal liver tests and a bit of PBC on biopsy.
Okay, thank you. Last question, and I'm not sure if I'm going to pronounce this properly. I don't mind being thick. Are you able to tell the purpose of elastography?
Yeah.
Scan? I'm going to have the scan and wondered why it was being done.
Yeah. So I've already mentioned elastography. So FibroScan that I mentioned earlier is.
Oh, is that the same thing? Is it? Oh, right. Okay. So, yeah. Right.
FibroScan is basically like FibroScan is like the Hoover to a vacuum cleaner. Yeah. So elastography is the vacuum cleaner, right? That's the technology. Okay. Hoover is the brand. So FibroScan is just a brand of elastography, but it's the commonest brand. Okay. So unfortunately, we do slip into using the jargon and calling it the brand. Like everybody calls the vacuum cleaner the Hoover, don't they?
Yeah.
So basically, a FibroScan is a way of measuring your liver stiffness using a technique called elastography. So elasto just refers to how elastic or how rubbery your liver is. Your liver should be nice and soft and flexible rather than hard and knobbly. And so it sends vibration waves through your liver and tracks how fast those vibration waves travel through your liver. So elastography is the property used to determine how hard or stiff your liver is. It's a really good way of ruling liver damage out. And if your liver stiffness reading is normal, then you don't have any liver damage. It's very accurate at detecting.
And that's not uncommon. Right. Well, everything, thank you on the screen here. You're very welcome. Thank you so much. Now, there's a couple of things I'm just going to say to everybody. I've had an enormous response from you when I announced that I would be standing down as CEO once they found me a replacement. Please don't think I'm ever going to leave you, desert you. I've got PBC. I'm one of you. We're all in this together. So please don't think that I'm not going to be here because this PBC Foundation has been my life. So I won't be CEO. You'll get somebody younger, bright and smarter than me taking us into the next step. So I'm always going to be here. Hi, Chris. Hi, Alan. And secondly, I would say to you, we are going through a recession. I've seen worse than this in my younger day. Chris will tell you he's old enough to know this as well. So is Alan. But please keep donating to us because we don't get government funding. Everything we do, I know it's free to you, but we have to go and find the money. So if you can, just go onto our website. Somebody did say, look, can you start putting out your bank account details in more frequent places? So Alan's in charge of that. He's going to do that. And so, Andy, that was an amazing session. You just get through them all the time. It's fantastic. Thank you so much for giving us your time. And if we can do anything for you, but now that things are moving about, we'll maybe come down to Wales and do another wee conference. Last one we did was in Cardiff, and George Mills came over because we didn't know any Welsh doctors, but now we have your good self. You'll be stowed out. There'll be no room to do it.
We'd love to do it.
Okay, well, look, and thank you. I mean, Chris is in the background, Alan, and Linda as well, and they're all working, firing things into me. So thank you to the team. We've got a brilliant team at the foundation. And Andy, thank you. And if we can do anything for you, don't ever hesitate to say. But thank you to you, and thank you to everybody. And have a lovely Easter. No eggs, no chocolate, not allowed.
I'm allowed.
You're allowed. Okay, just one. Okay, thank
Andy,
you.
thanks
Bye,
for coming
everyone.
on.
Thanks very much. Thanks, Andrew.
Oh, we're going to
Cheers,
miss you.
everybody.
Don't
Bye.
moan, I'm still going to be around. You can't get rid of me. Not quite yet, anyway. Okay,
Right,
bye.
I'm going to close Facebook down now, okay?
Okay,
Have a
thanks.
great Easter,
Happy
everybody.
Easter.
Thanks, Andrew.
Cheers.
Take care,
Bye.
Chris.
Bye.
See you soon.
Cheers, Andrew.
Yeah, all the best, Alan. Have a good break. You off anywhere?
I'm going up north with my granddaughters for a wee while.
Oh, lovely. Which what? Northwest, northeast?
Sort of heading up northwest, a place called Thain. So it's about 30 miles south of Glencoe.
Beautiful.
So
Beautiful.
I've got
Yeah.
an en-suite hiker's hut.
That'll be lovely.
So I'm looking for. I've been there before. It's a great location, but my daughter just phoned me a wee while ago to say that my granddaughter's actually ill.
Oh,
So
no.
I don't know if one of them's be able to go or not. I'll have to wait till tomorrow. But
Well, fingers
that's
crossed.
the
'Cause,
plan.
yeah,
Fingers
beautiful
crossed,
spot. Amazing.
So yeah, so we're only, I think we're about 40 miles away from Oban, so we'll get down there for a day. That type
Well,
of
yeah. What can you possibly do in Oban for the day?